Welcome dear students. Today our topic of deliberation is Epidemiology of Foodborne Diseases Part 2. The main objectives of today's deliberation are Epidemiology of Foodborne Diseases, Foodborne Disease Outbreaks, Study of Impact of Foodborne Diseases, to study the surveillance and monitoring of foodborne diseases, and strategies to overcome the foodborne diseases. First, let's understand what epidemiology is. Epidemiology is the study of distribution and determinants of health-related states and events in populations and the application of this study to control health-related problems. In the context of health and disease, epidemiology deals with the following: what causes disease, how does disease spread, what prevents the disease, and what works in controlling disease. Melton Terris, a leading exponent of close interrelationships among epidemiology, public health, and policy, has summarized the functions of epidemiology as: number one, discover the agent, host, and environmental factors that affect health in order to provide the scientific basis for the prevention of disease and injury and the promotion of health. Number two, determine the relative importance of causes of illness, disability, and death in order to establish priorities for research and action. Number three, identify those sections of the population which have greatest risk from specific causes of ill health and benefit from specific interventions in order that the indicated action may be directed appropriately. Number four, to evaluate the effectiveness of preventive and therapeutic health programs and services in improving the health of the population. Dear students, now let's learn about foodborne disease. Foodborne disease is caused by consuming contaminated food or beverages. Many different disease-causing microbes, pathogens can contaminate food, so there are many different foodborne infections. In addition, poisonous chemicals or other harmful substances can cause foodborne diseases if they are present in the food. Although majority of the foodborne illness cases are mild or self-limiting, severe cases can occur in high-risk groups, resulting in high mortality and morbidity. The high-risk groups for foodborne diseases include infants, young children, the elderly, and the immune-compromised persons. Now, dear students, let us learn about how foodborne disease outbreaks. An outbreak of foodborne illness occurs when a group of people consume the same contaminated food and two or more of them come with same type of illness. It may be the group that ate a meal together somewhere, or it may be a group of people who do not know each other at all, but who all happen to buy and eat the same contaminated items from a grocery store or restaurant. For an outbreak to occur, something must have happened to contaminate a batch of food that was eaten by the group of people. Often, a combination of events contributes to the outbreak. A contaminated food may be left out at a room temperature for many hours, allowing the bacteria to multiply to high numbers and then be insufficiently cooked to kill the bacteria. Now, coming to the symptoms of foodborne illnesses. Common symptoms of foodborne illnesses are diarrhea and/or vomiting, typically lasting 1 to 7 days. Other symptoms might include abdominal cramps, nausea, fever, joint or back aches, and fatigue. What some people call the stomach flu may actually be foodborne illness caused by a pathogen, for example, a virus, bacteria, or parasite in contaminated food or drink. The incubation period, that's the time between the exposure to the pathogen and the onset of the symptoms, can range from several hours to 1 week. Now, coming to the causes of foodborne illnesses. The Food and Drug Administration, FDA, lists 5 foodborne illness risk factors. They include improper hot and cold holding temperatures, improper cooking temperatures, dirty and or contaminated utensils and equipment, poor health and personal hygiene, food from unsafe sources. During recent decades, there are major epidemiological shifts in foodborne disease due to cultural and demographic factors as well as increased mobility. The foodborne diseases of earlier times were smaller and limited in scope, more often originated in the home and were associated mostly with Staphylococcus or Clostridium species. Technology has now provided the means for mass production and distribution of food. Therefore, foodborne disease often occurs on a massive scale. The effects of foodborne disease are more likely on children and old age persons as well as immune compromised patients and pregnant women. There is higher incidence, morbidity and mortality among these groups. The effect of foodborne disease may extend beyond the immediate illness. Most foodborne disease have a short duration of illness and a self-limiting course. Cryptosporidium and Cyclospora may cause a more protracted disease. However, some foodborne diseases are associated with long-term chronic sequelae. Campylobacter species, Salmonella species, Shigella species, and STEC 0157:H7 are most commonly identified pathogens. One of the greatest attributes to these infectious agents is that they have developed extreme tolerance to cold, heat, and acidic conditions. In addition, they have developed multi-drug resistance and have been linked to prolonged illness and a greater risk of hospitalization. Almost any food can be a source of foodborne disease. However, different agents are associated with a particular type of food, like Salmonella has traditionally been associated with poultry and eggs, Campylobacter with chicken and unpasteurized milk, and STEC 0157:H7 with ground beef. An outbreak of STEC 0157:H7 was associated with steak that had been needle tenderized, therefore exposing the center of the meat to surface organisms. When the steak was not thoroughly cooked to an adequate internal temperature, the microorganisms survived and illness occurred after consumption. Now, dear students, let us learn about the impact of foodborne illness. Number 1, public health impact. Foodborne illnesses are prevalent, but the magnitude of illness and associated deaths are not accurately reflected by the data available in both developed and developing countries. To fill the current data gap, the WHO, that's World Health Organization, has taken initiative for estimation of global burden of foodborne illnesses. World Health Organization and the US Center for Disease Control and Prevention, that is CDC, report every year a large number of people affected by foodborne illnesses. Globally, an estimated 2 million people died from diarrheal diseases in 2005. Approximately 70% of diarrheal diseases are foodborne. It is estimated that up to 30% of the population suffer from foodborne illnesses each year in some industrial countries. Foodborne illness outbreaks are underreported, and it is estimated that 68% of the foodborne illness outbreaks are notified to the CDC. Even during foodborne illness outbreaks, only a small proportion of the total number of cases is reported. Now, the economic impact of foodborne illness. Every illness has an economic cost, and same is the case with foodborne illness. However, the economic cost of health losses related to foodborne illnesses has not been extensively studied. There are few studies available which provide either incomplete cost estimates or their estimates are based on limiting assumptions. Now, dear students, let us discuss monitoring and surveillance of foodborne disease. Any disease of an infectious or toxic nature caused by consumption of food is a foodborne disease. In order to address and manage food safety, it is imperative to have cost-efficient monitoring of food contamination and surveillance of foodborne diseases. Monitoring is the performance and analysis of routine measurements aimed at detecting changes in the environment or health status of populations, while as surveillance is the ongoing systematic collection, collation, analysis, and interpretation of data followed by the dissemination of information to all those involved so that the public health sector is maintained. To facilitate communication and coordination, establishment of a coordinating body with the participation of relevant stakeholders is recommended. The establishment of a dedicated multidisciplinary surveillance unit involving epidemiological and microbiological expertise from all sectors can facilitate this type of coherent data analysis and feedback. The need for a national approach. Now, why there is a need for a national approach? Because pathogenic microorganisms can enter the food chain at any point from livestock feed via the on-farm production site, at slaughterhouse or packing plant, in manufacturing, processing and retailing of food through catering and home preparation. Since there are various possible routes for transmission of pathogen throughout production, isolated actions cannot ensure lasting consumer protection. In order to effectively manage the problem of foodborne disease, measures should be considered at all levels of production. This requires a coordinated surveillance and response effort from all major stakeholders in food safety. The food industry is responsible for the quality and safety of their products and is therefore a major stakeholder in food safety. Now, surveillance to detect foodborne disease. Surveillance, as we already mentioned, refers to a specific extension of monitoring where obtained information is utilized and measures are taken if certain threshold value related to disease status have been passed. The main objectives of surveillance are outbreak detection, monitoring trends in endemic disease, everlasting interventions, and monitoring program performance and progress towards a predetermined control objective. However, surveillance is not merely a routine measure of current situation as opposed to monitoring, but a basis for giving qualified feedback to producers, tracing back contamination to its origin, pinpointing critical points during production, and initializing targeted action. There are various levels of intensity and coordination in surveillance system. Surveillance can be active or passive, general or sentinel, continuous or intermittent, disjointed or integrated. In general, the intensity of surveillance is a product of social, that is priority of disease, societal impact, practical, that is availability of epidemiological knowledge, and financial parameters. Integration of surveillance activities to the national level facilitates optimization and cost efficiency in generation and utilization of surveillance data. The challenge is to optimize the sensitivity of the surveillance system while minimizing the cost. For example, integration of surveillance components within and between links of a population chain, For example, to investigate possible associations between the levels of foodborne pathogens in food animals and in food products at retail, integration of different surveillance programs of the same production animal, for example, using the same serum samples for the detection of antibodies against both Salmonella and PRRS, integration of different surveillance programs for different production animals, for example, to estimate the relative contribution of the main reservoirs to the total number of human cases of foodborne illness, integration of national surveillance programs to rapidly recognize and report international outbreaks, for example, Internet, OOSFoodNet, and Global SalmServe. The integration of foodborne disease surveillance activities can be achieved through number one, communication. Communication between major stakeholders can be maintained during regular meetings and direct, informal contact between veterinary and public health workers in key positions. Number two, collaboration. Collaboration consists mainly of the routine exchange of data and participation in outbreak investigation and response. Number third, coordination. Control activities and the sharing of information need to be coordinated within and between the programs. Number four, central storage of data. Managing a central database containing all the surveillance data allows for coherent analysis of the relation between foodborne pathogen reservoirs and disease in time and space. Worldwide, there are various surveillance systems to monitor, investigate, control, and prevent illness. In addition to monitoring the foodborne illness, some surveillance activities also help in evaluating the safety of the food supply. Some of these food surveillance systems are FoodNet, Foodborne Disease Active Surveillance Network. FoodNet is the surveillance system in the United States. For FoodNet, CDC has collaborated with 10 emerging infections program EIP sites: California, Colorado, Connecticut, Georgia, New York, Maryland, Minnesota, Oregon, Tennessee, and New Mexico, the US Department of Agriculture, and the Food and Drug Administration. It performs surveillance for foodborne illnesses and also conducts epidemiological studies to determine the changing epidemiology of foodborne illnesses. It responds to new and emerging foodborne illnesses, monitors the burden of foodborne illnesses, and identifies their sources. It helps in understanding foodborne disease reporting in FoodNet surveillance system. It shows steps involved in the registration of an episode of foodborne illness in the population. Next is the PulseNet, the molecular subtyping network for foodborne bacterial disease surveillance. In the United States, PulseNet has created a national framework for pathogen-specific surveillance. PulseNet is responsible for molecular subtyping of foodborne illness surveillance. It helps in detecting widespread foodborne outbreaks by comparing strains of bacterial pathogens from all over the United States. It performs DNA fingerprinting on foodborne bacteria by pulsed field gel electrophoresis. By identifying and labeling each fingerprint pattern, it is possible to rapidly compare these patterns through an electronic database at CDC, thus identifying related strains. Electronic Foodborne Outbreak Reporting System, also known as eForce. The eForce database is a surveillance system that collects reports on foodborne outbreaks. It requires specialized knowledge and expertise to appropriately analyze and interpret the data. Various studies are conducted by analyzing the data collected within the E4S in various settings, such as schools, in order to examine the magnitude of foodborne illness, their etiologies, and to provide recommendations for prevention of foodborne illness. Now, dear students, let us discuss the strategies for control of foodborne illnesses. The contamination of food is influenced by multiple factors that may occur anywhere in the food production process. However, most of the foodborne illnesses can be traced back to infected food handlers. Therefore, it is important that strict personal hygiene measures should be adopted during food preparation. To prevent foodborne infection in children, educational measures are needed for parents and caretakers. Good agriculture practice and good manufacturing practice should be adopted to prevent introduction of pathogens into food products. In order to control foodborne viral infections, it is important to increase awareness of food handlers regarding the presence and spread of these viruses. In addition, standardized methods for the detection of foodborne viruses should be utilized, and laboratory-based surveillance should be established for early detection of the outbreaks. For the prevention of foodborne outbreaks, training of food handlers regarding appropriate food preparation and storage is required. In addition, effective environmental cleaning and disinfection, excluding the infected staff, implementing hand hygiene principles, and preventing cross-contamination are recommended. Proper processing of food is necessary to ensure the reduction or elimination of the growth of harmful microorganisms. Pasteurization of milk and dairy products and hygienic manufacturing processes for canned foods will help reduce the cases of foodborne illnesses. Food irradiation is the recent technology for the prevention of foodborne illnesses. The food irradiation methods include gamma irradiation, electron beam irradiation, and X-ray irradiation. However, all food products cannot be irradiated. The consumers should also take precautions to prevent foodborne illnesses. These include cooking meat, poultry, and eggs at proper temperatures, proper refrigeration and storage of foods at recommended temperatures, prevention of cross-contamination of food, use of clean slicing boards and utensils while cooking, and washing hands often preparing food. And lastly, let's understand the detection of foodborne illness outbreaks. The primary goal of surveillance for foodborne disease outbreaks is the prompt identification of any unusual clusters of disease potentially transmitted through food, which might require a public health investigation or response. Detecting outbreaks requires efficient mechanism to capture and respond to a variety of data sources. In most countries, the main data sources for detecting the foodborne disease outbreaks are the public. That's the members of the public are often the first to provide information about foodborne disease outbreaks, particularly when they occur in well-defined populations at the local level. Public health authorities should have guidelines on how to deal with and respond to such information, and outbreak reports received by the public should never be dismissed without consideration. When reports of an outbreak are received, the following information should be gathered: the person or persons reporting the outbreak, characteristics of suspected outbreak, clinical information, suspected etiologies, suspected foods, persons directly affected by the outbreak, that is the epidemiological information. Number second source which can report an outbreak is the media. The media are usually very interested in foodborne outbreak reports and may devote considerable resources to detecting and reporting them. A local journalist may be the first to report a foodborne disease outbreak. Public health authorities may first learn of a possible outbreak through media reports. journalists may detect outbreaks that have been hidden from the health authorities because of their sensitive nature or because of legal consequences. Number third, the reports of clinical cases may come from the healthcare providers. Healthcare providers may report clinical cases on unusual health events directly to the public health authorities. Information received by astute or concerned healthcare providers should always be followed up unless there are very good reasons not to do so. The rationale for not acting on such information should always be explained to the healthcare provider in order to maintain credibility. Number fourth is the surveillance data. Now, surveillance activity are conducted at local, regional, and national levels throughout a variety of systems, organizations, and pathways. Among the many surveillance methods for foodborne diseases, laboratory reporting and disease notification may contribute importantly to outbreak detection. Other types of surveillance that may be of value in detecting foodborne disease outbreaks are hospital-based surveillance, sentinel site surveillance, and reports of death registration. Laboratory-based surveillance, that's the laboratories that receive and test clinical specimens from patients with suspected foodborne disease, for example, fecal samples from patients with diarrhea. Often positive microbiological findings from these specimens are also sent by laboratories to the relevant public health authorities. In addition, some laboratories send patient material or isolates to a central reference laboratory for confirmation, typing, or determination of resistance patterns. The collation of these reports and their systematic and timely analysis can provide useful information for detecting outbreaks, particularly when cases are geographically scattered or clinical symptoms are non-specific. Detecting outbreaks is facilitated by early typing of isolates of foodborne pathogens. Now, disease notification. In most countries, medical practitioners are required to notify public health authorities of all cases of certain specified diseases. Notification of cases is usually based on clinical judgment and may not require confirmation by other diagnostic means. It is widely recognized that most statutory disease notification systems suffer from substantial underreporting of diagnosed cases and long delays in notification. Moreover, many people with foodborne disease do not seek medical advice or will not be diagnosed as suffering from a foodborne disease because of the non-specific nature of their symptoms. Medical practitioners who become aware of unusual clusters of diarrheal disease or other symptoms that may indicate foodborne disease should also be urged to report these promptly to public health authorities. With this, we come to the end of today's deliberation. That was Epidemiology of Foodborne Diseases Part 2. Thank you for your attention. Have a great day. Goodbye.